Perfect. So I think we can start. So hello everyone. Thank you for joining us at this scientific series. Bienvenue tout le monde et je voulais juste vous dire que vous pouvez bien sûr poser vos questions en français ou en anglais. Thank you very much, Dr. Baumbusch. So Jennifer Baumbusch is a professor at the School of Nursing at the University of British Columbia and former CIHR chair in sex and gender science with a focus on family caregiving for people living with dementia. Her clinical area of expertise is nursing care of older adults. Jennifer's research program focuses on improving person and family-centered care for older adults and people living and people with lifelong disabilities. She's an associate editor with the International Journal of Older People Nursing and on the editorial boards of The Gerontologist and the Journal of Family Nursing. Welcome. We are thank you. Welcome, Dr. Dam. It's your turn.
Perfect. Thank you very much. And thank you so much for having me and welcoming me into your space today. I am joining you from Vancouver, British Columbia. And I just wanted to also acknowledge that the UBC campus is located on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. And if you come to visit us, this is a picture from our main mall when it's in its spring glory, which is probably about how it's going to look in a couple of weeks once our cherry blossoms are all done. So today I was invited to come and talk about my program of research in family caregiving. And the learning objectives are to understand the current context of family caregiving in Canada, recognize the complexities and challenges for family caregivers as they navigate the healthcare system, and identify best practices, evidence-informed programs, and policies that can support family caregivers. So whenever I'm presenting about families, I always have some provisos before I start. And so it's important to remember that family is who the person says they are. And so whenever we're working with people clinically, we always ask them who's in their family. And this can include families of origin or their biological families, their chosen families, blended families, and it can also include friends and neighbors. And that illness is a family affair. And oftentimes as we get into adult care, we look at it as treating the person or caring for the person. But when they do have a family and they have family caregivers, we're always treating the family as well. Many years ago, Nina Chappell and Colin Reid, some of my favorite researchers in family caregiving in Canada, talked about optimal involvement in their research. And I think this is a really key aspect of caregiving research, and that it looks different in different families. And so you have those families where, you know, they're there 24/7, they're doing hands-on care. And then you have people who are doing caregiving remotely, and they might live in a different province or different country. And that even when people are living close, they may or may not choose to be involved in different aspects of care. So I really like the language of optimal involvement, and I think that we should always be asking families and family caregivers about what that looks like for them, and not to make assumptions about what it should be. And we also need to remember that not every person is connected to a family. And these are often the people in our healthcare system who are at the greatest risk and the people that we need to pay the most attention to. And I also just wanted to say that I do research across the life course, but today I'm really focusing on my research with older families, but I also do research with families of children with disabilities and different populations. So I wanted to start by talking about the context of Canadian caregiving, because I think this is a really important aspect for people to understand in relation to the research. So this is a slide I've had for a really long time. As you can see from the dates of the stories, are all over 10 years ago. So I've been a nurse now for 30 years, which is hard to believe. And I started my career in gerontological nursing, or nursing care of older adults. And I worked in long-term care homes right at the start of my career. And this was what was out there. We talked about the aging population. We don't like to use language too much of gray tsunami anymore. That's considered quite ageist, but these are publications again from over 10 years ago. This was in the news, in the news, in the news. So it shouldn't be a surprise to anyone that our healthcare system should have been prepared. Shoulda, woulda, coulda, because that's what we've been talking about now for almost 3 decades, that we have an aging population. We need to prepare our healthcare system for our aging population. But what we see and what we know is happening is that this preparation didn't happen adequately enough to actually meet the needs of older adults in Canada in 2025. So, what are some of the issues that are contributing to the crisis in our healthcare system as this aging population requires more care? So we see in the news a lot lack of primary care. People are not connected with family physicians, nurse practitioners, other primary care providers. And this is a real crisis because people who are older need longitudinal primary care in order to get the supports and services that they need. We have shortages of healthcare professionals and healthcare workers. In my profession of nursing, we have a health human resource crisis. We have a shortage because just like our overall population is aging, the population of our health professionals are as well. And so we have nurses moving into retirement and not enough nurses to replace them to meet the needs of our population. This is also happening in medicine and other health professions. And that's also contributing to the lack of primary care providers. As we see GPs who have been in practice for decades retiring with no one to replace them or pick up their practice. So what does this result in? Overuse of emergency departments as an entryway into the system. People who don't have primary care access are going to the emergency department looking for care. They're in a crisis. And in the news, almost every day, we're seeing issues around overfilled emergency departments, long waits. In British Columbia, we also regularly hear about closures of emergency departments where there's not enough staff. I'm sure that may be happening where you are as well. It's certainly happening in Ontario. We see that a lot in the news. And so not only do we have more and greater need for emergency departments, we have less of them open, we have less staffing. The other issue around emergency departments that I've done a bit of research around is that they're not really set up for the needs of older people. And emergency departments can be very harmful to older people. And you have staff there who, rightfully so, are interested in emergency medicine and emergency care, and not so much have training and preparation to look after older people and what their care needs might be. We have surgery wait lists. This has been ongoing for many years. And we have wait lists for long-term care homes and assisted living placements and retirement homes, or however they're called across the country. So all of this is causing people to stay in community for longer. In British Columbia, there are long wait lists for long-term care homes. And once people move into a long-term care home, they're typically there for about a year and a half before they pass away. So long-term care homes have really transformed as well over the years into places where people are receiving end-of-life care, as opposed to spending several years of their life there. The other two things that I wanted to put on here and I put in red are things that we didn't anticipate 30 years ago when I was starting my nursing career. That first one is the COVID-19 pandemic, which we're still feeling the results of and the impact of on our healthcare system. It had multifaceted effects on this population and also climate change impacts. And I'm starting to do a lot more work in the area of climate change in older adults, realizing that they're a very vulnerable population. And in my own research, I had an incident in one of our studies in 2021 when we had a heat dome here in Vancouver, where a caregiver who was looking after a family member in community at home, and the family member was a person living with dementia. Their caregiver actually passed away during the heat dome. They had a cardiac arrest and they died at home before the paramedics arrived, because during that 3-day period, we also had a crisis in our emergency services, and ambulances were spread really thin, and so no one got to the home before the caregiver passed away. And the result of that was that the person living with dementia needed to go and live in a long-term care home because they no longer had a caregiver at home. So there are multifaceted impacts of climate change on this population, and that also impacts their family caregivers. So this is all of what's swirling around in our healthcare system with our older people, and the strains within our system. And I wanted to talk a little bit more about how older adults utilize our healthcare system. And this is a quote from a study I did many years ago with nurses working in hospitals, where we were actually providing some education and training around working with older adults. And one of them said, if you just went up to somebody and said, tell me about geriatric nursing, I think most people would say, well, that's long-term care. That's residential. I think that's where geriatrics live. And there's this perception that if you're working with older people, they're going to be in long-term care homes and that's where you're working. And so we need to really think about where are we seeing older people in our healthcare system. And so currently, older adults represent about 19% of the population, so 1 in 5 people. And this is their healthcare utilization. So they're using 47% of all public sector healthcare spending, 40% of hospital stays. So 4 out of 10 patients in the hospital is going to be an older adult. 56% of emergency room visits. So 1 out of 2 people that you're seeing in the emergency room and presenting an emergency is going to be an older adult. 88% of home care. So not surprising, most of our community-based home care services are being used by older adults who are living in community. And 94% of residential care, what we call long-term care home. So even if you work in the healthcare system and you think, Matt, I don't specialize in older adults, I'm not interested in that, as there are huge issues around ageism and stigma of working with older adults. That's the people that you're going to see in your practice. And those are the people that are going to make up parts of your population if you're doing research, unless you're doing research exclusively in obstetrics and pediatrics. So it's really important that we understand that this is their healthcare usage. And who's looking after them? For the most part, family caregivers are. So in Canada, when we look at who are we caring for people who are in my age group, sort of in their middle age, as a Gen Xer, it's hard to accept that that's where I am. But most people, not surprisingly, are looking after aging parents. And so you're going to see lots of older adults with their middle age and getting into older adults themselves with their parents when they're presenting in the healthcare system. Then about 17% are caregiving for their partner or spouse. And then about 17% for another family member. And then that 10% or so who are caring for a child. And usually those children have lifelong disabilities. And in terms of the gender breakdown, pretty consistent over time that more women than men are caregivers. And there's reasons for that. Women live longer. There's a social perception around gender roles that women are going to be the caregivers. And we're just starting to have research around non-binary individuals. So in this Stats Canada report from 2018, which is the most current data that we have on caregiving from Stats Canada, about 1% of caregivers reported being non-binary. And I think that as time goes on, we'll see that percentage increase. So in terms of, again, where our caregivers are at their place in life, you can see that caregivers are mostly in that middle age range, what we often call the sandwich generation, where people, particularly women, are caring for aging parents as well as caring for their children. And then that starts to decline over time as people get older themselves and may no longer be able to fulfill that caregiving role. So this is a slide that I always like to include in this, and it can really cause some prickly feelings among healthcare providers when I present this, because they don't always like to be told that families are actually our biggest workforce in healthcare. And so if you look at this, we have about 2.8 million family caregivers in Canada, and even though we know that nurses, regulated nurses, are the largest of the health professions at about not even 500,000. So not even half as many nurses as there are families who are engaged in care in some way. So we really need to be inclusive of family caregivers when we're talking about our healthcare teams and looking at our planning and all of the aspects of care provision, because they're the ones that are actually doing the day-to-day work most of the time. So the next part of the presentation is really around the second learning objective, around some of the complexities and challenges that caregivers experience within this context of healthcare. And I've presented some of the stats around caregiving, and the data that I'm presenting in this section of the talk is from my research program, which is mostly qualitative research, but it really illustrates what we see in the quantitative data that people have done around these issues. So one of the things I think we don't acknowledge enough in family caregiving, particularly family caregiving with older adults, is where these families are in their life course. And this is a really important thing because if you look at family life course theory, families have different tasks that they engage in over time. And so when we look at families that are in this stage of life, which we would consider later life, and look at some of those developmental tasks that they're doing. These are families where, the individual needing care or the individual providing care are retiring or leaving the workforce. And there can be lots of age-related and multimorbidities that are impacting all individuals, not just the person that we consider to be the care receiver, but also caregivers. And so there's a lot of what we would call work going on around transitions in family roles and responsibilities. And these are all things that we need to take into consideration when we're working with families and thinking about what is happening in the wider context of those relationships that have existed for decades. So this is from a study that we've actually just been doing now, and it was really interesting to me the number of reflections that came up from family caregivers, and we were interviewing them about care they're providing for a family member who's living in community. And these were a couple of older children, and this is some of their comments. And the first one was a daughter who said, I just want to say I love my mom. I want whatever transition comes, whatever, whenever, to be easy for both of us. And my friend today said, it's going to be okay for your mom, but it's not going to be okay for you. And so when we think about family members and adult children, they're grieving the loss of a parent, even when that parent's still alive, grieving that parent who is, no longer able to invite everybody over for family dinners. And there's a lot of shifting of family rituals during this time. And so even if that older person is moving through this in an okay way, that caregiver is still working through their own feelings about that. And this was a quote from his son, and he's talking about his conversation with his mom. And she even said to me, she said, well, I love you very much, but I like being in an assisted living with home support. And he said, because she can see how hard it was that I worked. And I don't think she wanted me to do that. It's very difficult when you have to change a pull-up on your own mother. It's very humiliating for your mother, for your son to do that. Maybe if it was a daughter, it would be different, but her daughters won't do that. So this also talks about those gender roles and that sometimes people surprise us, and it is the son or the husband taking on very personal care for people and what that means for relationships. If, for the first time in your life, you're helping your mom, with going to the washroom, with, you know, taking a bath or a shower. These are things that people are processing as they're expected by the system to be doing all these things. Well, nobody goes to classes when they become an adult to say, how do you give your mom a bath? You're just told in an interaction with a healthcare professional who may or may not ever see you again, well, you're going to need to do that. And all of the sequelae of what happens of that relationship, how do you even broach that conversation with your mom that I'm going to give you a bath or a shower now? In families that don't have experience in this kind of caregiving work, those are really hard things. And yet we expect them to do it with very little conversation and very little acknowledgement of what's happening in their family context through all of these changes. So with that, I'm going to shift now to talking about how this plays out in different settings. So hospitals, if you like that book about the terrible, no good stuff, that children's book, I can't remember the whole title, but hospitals are terrible places for older adults, and we know that. But they're also, as I said before, being used as an entryway to community-based services. So people need to get to a crisis, a real crisis that requires a visit to the hospital before they're getting connected to community services. So some of the things that we know are negative outcomes for older adults who go to the hospital: increased risk of delirium. That's a huge risk. Even a short stay in the emergency room can lead to a delirium. Hospital-acquired infections, from which they'll never go home again if they get a hospital-acquired infection. Falls can happen. People are in unfamiliar environments. Lots of times hospitals have those slippery floors. There's lots of issues with perception, and so and with side rails from hospital beds, and people can fall and break a hip. And permanent functional decline. And so they're very harmful spaces. And what we want to do is minimize people's time in the hospital. There can also be potential positive outcomes from being in the hospital, and this can include identifying underlying medical conditions. So this is a place where you could get the investigations done to find out a new health issue. Medication reconciliation. A lot of older adults present to emergency departments because of complications due to polypharmacy. And that's when there's different definitions, but typically when you're on 5 or more prescribed medications. And so the hospital is an opportunity to have a pharmacist really look at what you're taking and whether or not it's all appropriate. Rehabilitation of function and mobility. If you have a really good hospital stay, see a physio and OT, things could improve. And referral to appropriate community-based supports. It can also provide caregiver respite, because if you be providing 24/7 care at home, when someone goes into the hospital, it might be the only time that you have to clean your house, have a nap, take care of yourself a bit. We do see unfortunate stories where older adults are dropped off at the hospital and abandoned because their caregiver is burned out and no longer able to do that care. So in the study that we've been currently doing, it's been really interesting because we've had about 45 participants or so, and only 2 of them got connected to community services through their primary care provider. Every other single person, the person they were caring for went to hospital, had an emergency, and it was through the hospital that they were referred to community-based services. This is not a great way to run our system. And this was a quote from one of the participants. He said, "The hospital was saying to us, take him home, we can't have him. I was pushing to keep him in the hospital and stand my ground. But they went and said that, well, then we're going to go send him to respite," which the family didn't want. So the older mom took her husband home. And guess what happened when he came home that day? He fell right out the gates. It's just like, you've got to be kidding me. The get up and go is perfect. So this was said sarcastically, and if you work in acute care and have heard of the get up and go test, this is a test that is sometimes used to prove that an older person is ready to go home. And so obviously the dad had passed the get up and go and was sent home from the hospital, and then immediately fell as soon as he got in. So this is also a cycle that families are finding themselves in, this revolving door of the hospital, and it's not going well. And eventually that older person will end up needing placement from the hospital into a long-term care home. In my own nursing practice, when I started nursing, it was it was typically common and quite rare for people to move into a long-term care home following a hospitalization. People were admitted from community. Now, the majority of admissions to long-term care homes are from the hospital after a crisis. This, again, if you tie that back to the family, a lot of people, you don't expect that the outcome of that hospitalization is that you're never going to see your home again. You're never going to see your things. You're not going to get to say goodbye to your neighbors, maybe. That is it for you. You've been now transferred to a long-term care home. It won't be one of your choosing because we have a first available bed policy. And again, it can cause a lot of health and also mental health issues. But that's the current way our system is functioning. In terms of community-based services, families often find them unreliable, inflexible, an anonymous bureaucracy with endless wait lists, and that it's very reactive and not proactive. So in the caregivers that we've talked to, and this is in many studies that I've done across my career, is that it's really not until the caregiver is absolutely in a crisis that more services and supports are offered. Oftentimes people describe that they have to be a squeaky wheel in order to get what they need, which means that a lot of people are being lost and forgotten in the system. And this happens in both systems level and on individual in-home supports. So in terms of systems navigation, one caregiver said, I had no idea how anything works. Now, if you think about yourself sitting there, would you know how to access services in your area? If you had an older relative who needs care today, where do you go for that? Who do you call? How does that work? She said, I just had no idea. When I finally did speak to a case manager, I had said I was waiting for a doctor's referral. Not surprising. Lots of us are waiting. We think somebody from the healthcare system is going to recognize this crisis before we do and make a referral or do something. But that doesn't happen. And the case manager said everybody does, and it never comes. And like it really has to be someone, the caregiver, reaching out. And this again plays into that scenario of, well, they're going to reach out by going to the emergency department. And from that emergency department, they're going to be referred to community-based services, for which there will be a wait. And so people, a typical person, they don't know how this system works. They don't know how to access it. And increasingly, the person, if they are connected with primary care, isn't telling them what to do or providing advice. And then in terms of in-home supports, where typically an unregulated healthcare worker will come into the home and provide some assistance with activities of daily living. A caregiver said there's a different person every time, so you can't relay any information to them. And they come in and my dad says, well, I'm not hungry. So they go, okay, goodbye. Or I don't need a shower. Goodbye. And they're gone in 5 minutes. They're in and out. And typically these visits, maybe they're planned for 30 minutes or up to 2 hours at a time. But the unregulated healthcare worker will take their direction from the client. And oftentimes, if you work with the older person, they're going through a whole bunch of processes themselves in terms of learning how to accept help, even getting to that. So they'll have this stranger show up at the door, someone they have never met before, do not have a relationship with, who wants to give them a shower. Well, how would any of us react to that? Am I going to let a strange person who's shown up at my door help me in the shower? Ew, probably not. So it's not a surprise that older person will say, oh, I don't need a shower today. And then the healthcare worker, according to their instructions from their employer, will leave because they're there to provide assistance with activities of daily living. And if that person doesn't need assistance with activities of daily living, they are not expected to make that person a cup of tea and talk with them for 10 minutes so they can get to know them, so that person can have some social engagement today. That is not included anymore in our community-based services. So they will just go. And that older adult will not have received care. And the healthcare system says, well, they don't need that care then. Why are you telling us they need care? Because the healthcare workers are showing up to give the care, but the person says they don't need it. And it's like this cycle, right? Where then the services can be eroded and taken back, and then they hit another crisis and go to the emergency room again, and they're put back in place. Or maybe that person can't go home again. So from a caregiver's perspective, this system is chaotic and unreliable and not offering any help. We have examples of caregivers who we call in our study non-users. So they're not actually tapping into any of the community-based supports that they could. And what they tell us is, well, nobody told me they existed. Like, I don't know that there's day programs for older adults. I don't know that there's respite programs. Nobody told me. So they're getting into a greater crisis at home, and nobody from the system, our case managers, are telling them. And one of the reasons for that is that in our current system, case managers no longer have their own clients. that they would see over time. You get who's there today, or there's a lot of turnover in those roles because they can burn out really fast because you see all these people needing care and supports and you're not able to give them any. And so those healthcare providers are also leaving those roles. So there's no continuity in relationships and no understanding of what the true needs of those older adults are. So that's what's happening in our community. In a different part of my research program, I do a lot of research in long-term care homes. And this started even at the time of my dissertation and really seeing that families are providing a lot of care inside these care homes. And if you're familiar with long-term care homes, they're places where the people are frail and complex and require regulated nursing care around the clock. So in BC, we used to call these extended care homes, long-term care homes, residential care, and now they kind of fit under this umbrella of long-term care homes. And long-term care homes, and we saw this during COVID, and I'll talk about that in a moment, can't really function without all of that unpaid labor from family caregivers. And so in our research, some of the key roles that we found family members were providing, and this isn't just for their own relative or person that they're caring for who lives there. They do this for the resident population. So again, thinking about those people who have nobody or no supports or no local family, family members are filling in for families, filling in for staff. So they're definitely supplementing care provided by paid providers. This is especially during meal times. So if you're familiar with how meal times go in care homes, there's not a lot of time and a lot of people need to eat. And a lot of those people need assistance with eating, whether that's organizing their plate or actually assisting them to get the food into their mouth. And so family members oftentimes are doing that for their own relative or doing that for other residents that are at the table with their relative. They also know a lot about what people like and don't like. So I've had caregivers in my studies where they would run the whole snack time so that the care aides could go on their paid breaks, because otherwise the care staff weren't getting their breaks during a shift. And so when it was tea time, that family member knew how everybody wanted their tea prepared. They knew what kind of cookies they wanted or what kind of snacks they needed. They were on a special diet, and they would run that, and the care aides went on their break. They do a lot of advocacy, both individually for their relative, but also collectively. So family councils play a really important role in sort of lifting up the care for everybody. And those family members who are committed members of their family councils are doing that work. They're saying, hey, this doesn't just need to improve for my relative, but this needs to improve for all of the residents. And let's make some changes to make sure that happens. They're also really keen promoting social connections. I had lots of examples of family members who would run little social programs on their own, being really careful not to interfere with recreation therapy. But those family members who had special skills like gardening created their own gardening program, or playing music on a piano. They would come in and they'd give little concerts. Um, I've also seen family members who do this with their pets. They bring in their dog to visit their relative, but the dog ends up visiting a whole lot of people and bringing a whole lot of pleasure to those people. And also just at dining tables or in social rooms, you know, promoting those social connections, prompting conversations, trying to get people talking to each other. Family members are doing a lot of that if you kind of sit back and watch what's going on in your care home. And also really recognizing personhood. And this is a really key role for family members. And one of the things that I've noticed is that because family caregivers often have experience with their own relative, having been on that dementia journey or that journey of frailty and medical complexity with their relative, they have a really high degree of empathy for the other residents. So if you've been in a care home situation where you might be in a group where there's a lot of people who have advanced dementia, maybe in a closed unit, those family caregivers have a lot of insight and understanding of what has happened to that individual. So they really oftentimes will see the person in ways that staff don't. And so one of the daughters had said, I make a special effort to know everybody's name on the floor where my dad is, because each one of those people, they're a person. And this is something that family members bring very informally to a space, is knowing who people are, not necessarily having big conversations with them, but again, knowing how they like their tea. Isn't that nice to have someone bring you a cup of tea where it's made just the way you like it? That person knows you. That's really special. If we go to our local coffee shop regularly, if there's a barista who knows how we like our coffee, that's fantastic, isn't it? They learned that over time. That's what those family members are doing, right? They know who that person is. And that's a really special thing. So we know that during COVID, this all changed from one day to the next. These family caregivers, and there's a handful of them in every care home who are there every day or very regularly, seeing their relative and contributing to the care of all those other people, were suddenly not permitted to be there. And our team did a research study, as many people did during that time, to learn more about what was this experience like from the perspective of family caregivers. And one of them said, I don't think anybody will ever know the pain and trauma that family members who have lived through this. Like, it was awful and it was bad for them. And another person said, it took away my purpose and my identity. So, again, thinking about our own identities, who we are, what shapes our day. If you look at people who are retired, for example, you go to work every day, Monday to Friday, then all of a sudden you're not. That is a huge identity change for people. So, for people who are caregivers and for whom this is a big part of their life, this is how they structure their days, to have that gone from one day to the next was incredibly disruptive to them and to the people they were caring for. And she said, I've been a caregiver for so long. I found it quite debilitating. For the first 3 months, when I was entirely locked out of his life, I just kind of curled up and died. I found it mentally very hard to cope being separated from him. I think that hasn't been accounted for. Husbands and wives. You don't separate husbands and wives, and you don't do that when one is sick. That's half my soul in there, and they ripped it from me. I was forced out of his life. I was obsolete. I was written off. So again, lots of us have seen marriages that go on for 40 or 50 years. That's your everyday, that's your person. And one of the other things this highlights is we have to think of caregivers as not a homogenous group. And increasingly in my research, recognizing and being told by caregivers that the experiences of adult children are not the same as the experiences of spouses, as husbands and wives. And we need to think about that. As an adult child, you might have your own household and have stepped back from that role voluntarily or involuntarily, but still have that family that you're very much looking after or involved in, or maybe have work. And so you've got further engaged in your employment. But for spouses who were also retired or not in the workforce, who were going to the care homes every day, who this was their partner for life, all of a sudden being separated from that person, and that person wasn't dead. They were just on the other side of a door. Very traumatic. And that the ripples of this continue. So some of those caregivers are still very much caring for the person who's living in long-term care home. But we also see in long-term care homes that there's a huge erosion of the role of families. So even when those public health measures lifted and families were able to be more involved in care again, it never quite got back in a lot of places to where it was. There were still restrictions. There was still sort of a coming and going of things. And so we had sort of these waves of restrictions, of course. And so there's a lot of trauma around that family members experienced. So that was kind of my walkthrough of what's happening across our healthcare system with family caregivers. And I hope gives you a bit of a picture of, what is happening for people when they're engaged in this role in different settings. And so I wanted to spend the last part of my presentation really talking about strategies of support and thinking about how can we turn this boat around a bit? What can we do to better support this group that is providing so much care in our healthcare system, and upon which our healthcare system is so reliant and is more reliant on today than it was 2 or 3 decades ago. Our healthcare system no longer has the cushion to pick up where we lose our caregivers, our family caregivers. So it's concerning for me a few months ago when I received a message from a clinician, someone who works with older people all the time, who was very frustrated at work and said, Jennifer, how do we move families from being chronic complainers to conscious collaborators? And I thought, well, this is the big part of the problem, isn't it? Just the way we frame families as chronic complainers. What is that all about? How do we unpack that? But if that's how our healthcare professionals who work with aging families are going to work every day thinking about, oh my gosh, I'm going to need to deal with these chronic complainers again, that's a big issue. And that they need to become conscious collaborators. Well, we need to own that as the people who are being paid to work in the system. It's our job to foster a system where people feel safe to be conscious collaborators and not just to come in and complain that once again a piece of laundry has gone missing, or once again, the care plan wasn't followed, or once again, a care worker showed up and didn't do what they were supposed to do and just left. So when you arrive at the end of your day at work to look and check in on your dad, not only do you need to check in, but you also now need to give him a shower because the person who was supposed to be doing it had left. Like, there's a reason people are complaining, and we need to then create a system where they can be conscious collaborators. So how do we do that? So in our team's recent paper that we published, we talked about trauma-informed care. And trauma-informed care is becoming more prevalent in healthcare, which I'm glad about. I think that this gives us very practical tools and insights into how do we work together with people. Um, and some, and I think that, when we foster these aspects of care in our interactions, it can go a long way um, to creating those conscious collaborators. And also remember that these characteristics of trauma-informed care are something that I can do, I can promote in my own practice, but it's also ways that we need to reset the healthcare system to have this embedded into care. And I like this quote from one of the daughters who said, imagine dealing with this healthcare system at 90 years old with a spouse or somebody who has a dementia diagnosis, and you're just completely overwhelmed. Where do you even turn to? And that's the people that we meet in our practice. And so how do we start to do this? So these are the elements of trauma-informed care that are in the literature. And increasingly, we're learning how to teach this and build this into our healthcare systems. Safety. How do we make people feel safe when they're receiving care? Trustworthiness and transparency. So what does trust look like? Trust is being consistent. Transparency is being honest with people that this is how it works. Um, Also being transparent about how do you get more services. We don't need to hide that. People should know that if you need this new service, this is what you need to do. This is how you qualify. This shouldn't be a secret keeping endeavor for people who are in those formal care provider positions. Peer support is really important, and we see this across lots of different populations. And a lot of people are now doing this online, either formally or informally, but having places to connect with other people going through the same situation is really helpful for many people. Collaboration and mutuality. So really collaborating on that care plan, right? And thinking about, this isn't just something I write and present to you, but how do we work on this together? Empowerment, voice, and choices. Choices are something that people can feel empowered by, that there are different ways to approach this situation. Always thinking about people and families within the context of their culture, within the context of their history, and also gender context is very important. And the new element of trauma-informed care that our team came up with, particularly relevant to dementia care, is navigating uncertainty. So one of the things about dementia is that it is a disease process that unfolds differently for different people. There's a lot of uncertainty about when things will happen in that disease process, a lot of uncertainty about, what's going to happen, where is this care plan and this care support's going to go. So when we think about how to build things into our system and into our own practice, these are the really important things to pay attention to. In terms of education, we need to make sure that education is being provided to caregivers. There are excellent programs provided by the Alzheimer's Society of Canada locally in all the different provinces. And we also see people, receiving education through local hospitals and health authorities. And I think stroke care is an excellent example of this, where we oftentimes have people going to classes or diabetes care, and that we can offer classes to people about how to be a caregiver. And for healthcare professionals, we continue, even after my 30 years of being a nurse, not having fully integrated curriculum about older adults in our health profession programs, pre-licensure, or about people with disabilities and family caregiving. Even though you think way back to that slide at the beginning, these are the main people you're looking after. So if you're not in a class about obstetrics or about pediatrics, you should be learning about older adult care. And in your clinical placements, learning how to work with these families. That should be a key priority. And there is a really great program offered by Dr. Jasneet Parmar at the University of Alberta, and her program of research, which is called Caregiver-Centered Care Program. So even for people who are already in practice, if you think this is a gap and needs some professional development, that is a place to go and get that. Changing our systems. Caregivers need respite, 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 respite. And thinking about what that looks like and being innovative about it is something that all healthcare systems should be really focused on, because the more that caregivers feel prepared to continue in their role in community, the happier people are. People want to die at home in community, but we have to have systems that support the main people who are helping facilitate that, and that's family caregivers. You need to have clear navigation of programs and resources. A caregiver should be able to go on the website of their local health authority and figure out pretty seamlessly how to access care, and they can't. And to have responsive and flexible, be responsible and flexible, because the needs of those older adults change over time. People are not static. Their disease progresses. So what people need today might not be what they need in 6 months. So one of the family caregivers said to us, I wish there was a pathway that, almost like the yellow brick road, that you could follow it and say, these are the steps and this is what's on offer as you go along until you reach the end. And the last thing that we need are policies that enshrine and fund caregiving labor. And we need this federally and provincially. We have a relatively new organization in Canada called the Canadian Centre for Caregiving Excellence, which is they're doing excellent work around advocating, particularly at the federal level, around caregiving. And they have a national caregiving strategy on their website. There is the Canadian Caregiver Credit, but that is a tax credit, not cash. So it's great to have, but really mainly works for people who are already middle to high income. People who are low income, they need money to be able to do things, right? And we had that for a little while in the Canada Recovery Caregiving Benefit, which was a COVID-specific program and now defunct. But I think a lot of us who work in the area of caregiving thought, yes, we finally have something that is actually what caregivers are asking for and actually helpful. And then they only did it for a short duration during COVID. But what happened was people received money to buy groceries, money to pay rent so that they could be doing their caregiving. And one of the really unfortunate things about that trial was that it didn't fund existing caregivers. So if you were already providing care to somebody as an informal unpaid caregiver in Canada, you couldn't qualify for that benefit. It had to be someone newly dependent. And it was actually inclusive of people, for example, who lost their child care. So it might not have been caregiving for someone who was sick or ill, but a dependent child who no longer had child care. But this is the kind of thing that we need all the time, and should have gone way beyond COVID and way beyond new caregivers to support people. We also need to continue to have employment insurance for caregiver leaves and employer benefits. So when people are in unions or have contracts, to be advocating for employer benefits that will allow them to take time off if they need to take the person they're caring for to a doctor's appointment, or if they need a short period of time where that person's in the hospital and they can look after them. Those are the kinds of things that we need to be advocating for from our employers. And the last thing is around direct and individualized funding to hire family caregivers. So some of our healthcare systems already have this. And with the shortage of unregulated healthcare workers, that money is not necessarily being spent because there's nobody to fill those roles. And there are examples of programs in Canada and also the United States and other places where a family member or a client could receive funds for their care and then hire a family member to provide it. In some places, that family member needs to be hired by an agency. In some places, they would have a separate person holding those funds. There are different models. But certainly, if someone is providing 24/7 care, they ought to be receiving some monetary benefits from doing that. So that is what I wanted to share with you today. Thank you very much. If anyone wants to continue the conversation, I'm always happy to hear from people. You have my email on LinkedIn or Blue Sky. Always happy to chat and provide any of my publications that you're interested in having. But yes, thank you so much. This was really lovely for me to be able to talk about with you all for an hour. As you can tell, it's one of my favorite topics and something I've been working on for a really long time. So thank you.